Hello everybody. Today we are going to discuss about non-invasive ventilation. Non-invasive ventilation represents the respiratory support strategy designed to elevate respiratory distress without the need for invasive procedure, utilizing range of interference. This method involves the provision of continuous positive airway pressure and sometimes supplemented with pressure support during inspiration with primary objective of enhancing both oxygenation and ventilation. So widely adopted for the treatment of acute respiratory failure, encompassing both hypoxic and hypercapnic condition, particularly in critically ill patients. NIV has demonstrated efficacy in reducing the incidence of intubation and mortality. NIV is strongly advocated for managing conditions like cardiogenic pulmonary edema, exacerbation of the chronic obstructive pulmonary disease accompanied by hypercapnia. However, its applicability extends to the various etiologies of acute respiratory failure, including acute respiratory distress syndrome, viral or bacterial pneumonia, asthma exacerbation, neuromuscular disorder, thoracic trauma, mitigating the risk of extubation failure in high-risk patients, and among others. Effective NIV implementation hinges on appropriate setting and diligent monitoring to optimize outcome. The overreaching goal of NIV encompasses the enhancing minute ventilation, lessening the workload on respiratory muscle to mitigate failure, augmenting oxygen diffusion at alveolar level by elevating pressure gradient, averting or minimizing alveolar collapse, enhancing respiratory system compliance, and optimizing oxygenation and ameliorating hypercapnia. Now about indication hypercapnic respiratory failure like acute exacerbation of COPD, asthma crisis, acute decompensation of obesity hypoventilation syndrome. Then hypoxemic acute respiratory failure include cardiogenic acute pulmonary edema, ARDS, viral bacterial pneumonia, and acute respiratory failure in immunocompromised patients. Then about spatial scenario, prevention of respiratory failure, post-extubation in high-risk patient, perioperative at high-risk patient like obesity COPD, dyspnea relief in palliative care, pre-oxygenation prior to intubation in at-risk patient, and pre-oxygenation prior to the emergency intubation. So about acute decompensated heart failure, we can use CPAP of the pressure of 5 to 15 centimeter of water adjusted according to the patient's tidal volume need. FR2 of 50% can be increased if SpO2 remains below 90. It is desired effect is to improve myocardial performance and the respiratory mechanics. Now, now the when to decide about intubation at 1 to 2 hours, about when there is a depressed mental status, respiratory fatigue, and Hacker score of more than 5. Then acute exacerbation of the COPD, we can use pressure support up to 10 to 18, CPAP of 5 centimeter, target tidal volume of 10 to 15 ml per kg of predicted body weight, and the RR of less than 20 per minute. Offset auto PEEP and reduce the work of breathing and improve ventilation. Then we have to observe at 1 to 2 hours if there is respiratory fatigue despite optimal setting. Then uh, severe respiratory acidosis is there, and if HACOR is more than 5, then we need to take the decision of intubating the patient. Then acute hypoxemic respiratory failure. Then we begin with the CPAP of 10 centimeter of water adjusted to low tidal volume to reduce the damage. FiO2 of 60% should be adjusted to achieve SpO2 target of 88 to 92. Improve functional residual capacity, ventilation perfusion mismatch, reduce the respiratory effort. Then decision to intubate should be based on the Hacker score, which should be more than 5, high respiratory effort, tachypnea, despite maximum support and hypoxia. Now, monitoring during NIV, in accordance with the lung safe study, patient with the ARDS who encounter NIV failure and delays in intubation face a mortality rate of up to 45%, underscoring the necessity for validated tool to promptly assess the risk of failure in this patient. Upon initiation of NIV, continuous monitoring akin to that of any intensive care unit patient is imperative even outside of such a unit. This monitoring encompasses various clinical and biochemical parameters alongside the observation of each patient's sign and symptom. It is advisable to regularly evaluate whether the patient remains suitable candidate for monitoring this ventilatory support. Parameters such as patient comfort, tolerance to ventilation interference, respiratory rate, and oxygen saturation should be assessed every 30 minutes during initial 6 to 12 hours after commencing non-invasive mechanical ventilation and thereafter every hour. Additionally, the patient's level of consciousness can be judged using tools such as GCS and the Kelly-Mathieu score. Delirium linked to NIV failure ought to be assessed daily and routinely employing validated scales that like CAMP ICU score. ABG, regarded as a gold standard for monitoring respiratory failure, is advised 1 hour post initiation of NIV ventilation. Alteration in the pH and the PO to FiO2 ratio served as pivotal prognostic indicator in case of acute respiratory failure. Duane et al. Identified the most pertinent parameter of predicting NIV success in patients with hypoxemic ARS and proposed scoring system termed as HACOR score. HACOR score integrate clinical and biochemical parameters such as heart rate, pH, level of consciousness, PaO to FiO2 ratio, and respiratory rate. HACOR score exceeding 5 calculated within the first hour of NIV predicts the treatment failure. As a part of monitoring, vigilance towards adverse effects is paramount. Notably, these requiring scrutiny including interface disconnection, gastric distension, secretion, expulsion, pneumonia, pneumothorax. It is imperative to recognize that monitoring alone does not suffice to alter patient's outcome. Rather, it is action informed by this information that makes the difference in the patient care. Now about Hacker score, heart rate is if it is less than 125 zero score, if more than 121 score, then based on the pH is less than 7.254 score, more than 7.350 score. About consciousness, if the GCS is 15 zero score, if GCS is less than 10 score. About PO to FO2 ratio, if it is more than 200 zero score, if it is between 101 to 125 5 score, if respiratory rate more than 45 4 score, if less than or equal to 30 zero score. Now, consideration for the use of NIV. Several authors have pointed out certain facial features such as presence of beard, presence of placement of orotracheal nasotracheal tube may impede the achieving the airtight seal between the interface and the patient's face, potentially being considered contraindication for NIV use. However, this condition is often viewed as relative contraindication. The priority should be to ensure airtight seal by utilizing interface appropriate to the patient's size and if necessary feasible, considering the removal of facial hair. Primary consequences of the poor airtight seal is the cornerstone of leak, which can affect both the delivered volume and the cycling of the ventilator. Initially, adjusting the headband can address this issue, but it is important to note that relying solely on this measure can cause discomfort and intolerance to the interface and may even lead to the formation of ulcer on the nasal patch. So some ventilators have a system designed to compensate for this leak. It is relevant to mention the NIV programming with the support mode, typically exhibiting better compensation capability compared to the volume-based programming. When using flow cycle ventilation, leak can be hindered, achieving program expiratory trigger, resulting in prolongation of inspiratory time. Time cycle setting can reduce the patient's respiratory effort and have been associated with better interaction between the patient and the ventilator. Now, success and failure of NIV. NIV represents the useful and cost-effective method for reducing the need for intubation in patients with acute respiratory failure, heart failure, and exacerbation of COPD. However, it is well documented in the literature that its use without application of success and failure predictor is associated with delays in intubation and therefore increased mortality. For this reason, it has been constant effort in developing tools to predict the outcome of NIV. In case of COPD, failure rate ranging from 15 to 24% have been reported in previous studies. These studies have identified multiple variables that can predict NIV failure in COPD patients, such as disease severity, heart rate, respiratory rate, consciousness status, and blood pH. The independent factors have been integrated into what is known as HACR score. Additionally, the multi-centered study have demonstrated that various parameters are associated with high risk of NIV failure, including high severity score, that is Apache 2 score and the SAP score. Advanced age, lack of improvement 1 hour post NIV initiation, multi-organ failure, previous incapacity of self-care, pH of 7.25 on CO2 of exiting 75 mmHg, after 2 hours of NIV commencement and the respiratory failure without apparent cause. Regarding the success of NIV, positive predictors such as improvement in the pH, in first hour of therapy, a decrease in respiratory rate, and reduction in the CO2 levels are associated with positive response to the NIV. About discontinuation of NIV, similar to the invasive mechanical ventilation, specific criteria for early NIV withdrawal are crucial to mitigate associated complications. After resolving cause of ARA, following are the withdrawal criteria that should be sought. That is adequate oxygenation, pH should be more than 7.35. RR should be less than 25. Without the use of accessory respiratory muscle, patient should be hemodynamically stable. Kelly score should be less than or equal to 2. Absence of respiratory distress sign such as agitation, diaphoresis, and anxiety. Additionally, another crucial criteria for NIV withdrawal is the presence of failure predictor, which may include the high disease severity score, that is Apache 2, SAPS 2, and SOFA, advanced age, lack of improvement post 1 hour with NIV, multi-organ failure, premorbid state indicating self-care inability, mean pH of less than 7.25, mean PSU2 of more than 75 mg after 2 hours of NIV initiation in hypercarbic ARF, and difficulty in identifying ARF etiology, that is ARDS pneumonia, PaO2 FiO2 less than 120. Now about contraindication of NIV. Neurological, altered state of alertness, loss of protective airway reflexes, agitation, delirium, post-seizure state, stroke, acute polyradiculopathies, Bear syndrome, Guillain-Barré syndrome affecting respiratory muscle and cranial nerve, then respiratory, life-threatening hypoxemia, inability to handle secretion, intolerant to NIV, then hemodynamic, circulatory shock, uncontrolled arrhythmia, gastrointestinal, intestinal obstruction, hematemesis, persistent vomiting, then facial, laceration, fracture of facial bone with instability and burns. Thank you, guys.